reevaluation appointment is an important step after the completion of non-surgical periodontal therapy. At this appointment, the dental hygienist is able to compare pre-treatment assessments with post-treatment healing to determine if further action is needed. The reevaluation appointment is best performed at 4 to 6 weeks after the conclusion of periodontal therapy. This allows time for the tissue to respond and heal. Any sooner than 4 weeks may disrupt this healing process. So what do we do at the periodontal reevaluation? First, we need to update the patient's medical history, which is standard in any appointment. Next, we want to complete a comprehensive periodontal evaluation. Then we're going to compare the periodontal evaluation from the pre-treatment to the post-treatment results. And finally, we need to make appropriate decisions related to the next steps for the patient. When evaluating the next steps for the patient, we should identify any non-responsive disease sites. These may include sites that continue to bleed, show signs of continued inflammation, or even additional loss of attachment. Non-responsive sites should be checked for the presence of residual calculus deposits and biofilm accumulation, and the ability of the patient to provide adequate home care. If the patient is unable to properly clean the area, a new skill should be demonstrated to better suit the patient's needs. When local inflammatory factors like biofilm and calculus are found, these areas should be debrided again during the reevaluation appointment. It's not unusual for calculus deposits to be left behind inadvertently due to the presence of inflammation and edematous tissue often seen during initial therapy.
What?
That's right. Dental hygienists leave calculus behind even when we do a great job. The dental hygienist should consider use of antimicrobial agents and should also consider whether other factors may be contributing to the disease process, such as undiagnosed diabetes or the use of nicotine. It's important to be able to recognize when the patient may need a referral to the periodontist. If the patient presents initially with stage 3 or 4, it would be more obvious that a referral is warranted. But often a referral is not identified until the reevaluation appointment, when adequate treatment has not responded in the intended outcome and further evaluation for surgical intervention is necessary. If at any point the disease has severely deteriorated, or if the patient has significant systemic issues which complicate the disease process, a referral to the periodontist should be recommended. For most of our patients, however, scaling and root planing is the definitive treatment for periodontal disease, and proper follow-up and maintenance can occur within the general dental office. All patients who have loss of attachment due to periodontitis should be placed on periodontal maintenance. A periodontal maintenance program is especially important to prevent future progression or recurrence of the disease after the periodontium has successfully stabilized. Let's look at a couple of cases. Bella is a 23-year-old female who presents with generalized stage 1 grade B periodontitis. She had generalized plaque and super and subgingival calculus deposits which were visible on radiographs. She received 4 quadrants of non-surgical periodontal therapy along with oral home care instructions. At her follow-up evaluation, her comprehensive periodontal assessment shows marked improvement from the pre-treatment assessment. Her oral home care has been fair, but she has not been flossing as directed, so she does have new accumulation of biofilm interproximally. The tissue facial to number 7 is inflamed, erythematous, and rolled, and residual calculus is present subgingivally. Otherwise, she demonstrates great improvement in tissue appearance. What steps would you take for Bella? Because she has an accumulation of interproximal biofilm, full mouth deplaquing with an ultrasonic on low power is appropriate. We should also remove the residual calculus deposit on the facial of number 7. Additionally, we need to reinforce the need for proper oral home care. In this case, I might even discuss the use of a water pick, especially if this patient is reluctant to floss daily. Since this patient doesn't present with any urgent referral needs, I would set her recare appointment at 3 months and follow her closely. If her home care improved and her plaque buildup reduced, I would consider a 4-month recare in the future. Now let's take a look at DeMarcus. DeMarcus is a 45-year-old male who initially presented with generalized stage 2 grade B periodontitis. He was treated with 4 quadrants of scaling and root planing. At his reevaluation appointment, He has very little actual healing of the tissue and continues to have moderate inflammation, erythema, and bleeding on probing, despite having adequate self-care and biofilm control. He denies smoking, but admits that he has felt a little run down lately, and he thinks he's excessively tired from a busy lifestyle. You don't notice any detectable residual calculus or new biofilm accumulation. What course of action would you take next? Well, DeMarcus is showing signs that something else might be going on. He has refractory periodontitis that is not responding to a normal course of treatment, and he's been excessively fatigued. There's not much more that the hygienist can offer DeMarcus, and the best course of action would be to refer him to a periodontist who can properly assess the patient's overall health and manage this complicated case in a specialty setting.